can I request the moderators? We can probably start off with the introduction of the speakers for the next session. We've got an international panel,
Yeah.
and I think it'd be
So,
worthwhile. And we got a very prominent
yeah,
speakers. So if you can just introduce the panel, the speakers, I think.
yeah. So, as the topic of the session is the outcomes of surgery, of course, everybody outcome is the final word. Everybody is interested in good outcomes. Whatever it takes to get a good outcome is important, because that leads to a good satisfaction for the surgeon, a happy patient, and happy ending. So in this regard, we have amongst us Dr. Sigurd Berwin, who is a spine surgeon in San Francisco at the UCSF. And apart from his basic work as spine surgeon, he has some special interest in measuring the outcomes of spine surgeries. And he has studied multiple variables affecting different types of surgeries of the spine, specifically in the scoliosis group. And he has had several publications in this subject. So he would be a very good person to tell us how we can improve the outcomes of spine surgery. What are the factors that will affect the outcomes? And I welcome Dr. Sigurd Berwin to our meeting, and thank him for being here to present his thoughts on the matter. So I think it is just about 2 more minutes to start.
Yeah. One thing more, I was also just going through Dr. Berwin's, CV, and he has also studied politics and economics at Oxford, which is quite different from, medicine, what we normally, we are on a single track, but he has got quite a range of topics which he has studied when he was, in his formative years.
Yeah,
I think that has led to, more of, towards this topic that he has gone and, looked into the human aspect of the things.
Yeah, right. Multifaceted personality.
Thank you both for that very, very generous.
Hello, can you hear me, Dr. Gautam Zaveri?
Yes, Gautam.
Okay. Sushil, can you play the presentation, please?
Good morning, and thank you to everybody. I really appreciate the opportunity to contribute to the Congress, and that's terrific. If you want to control the slides, otherwise I can share my own screen, whichever you prefer. But if you control it, I'll advance. So this symposium is going to be on improving outcomes in spine surgery, and I appreciate the moderators and the course organizers for allowing the opportunity to contribute to the program. If we can go ahead to the next slide, I'm going to focus on complex spinal disorders. I think it's important to recognize that complex disorders are an important priority for our healthcare systems, really internationally. And I'll talk a bit about why complex spinal disorders are important and the range of disorders that involve the spine that we consider complex. Surgical management of complex spinal disorders really has a significant potential for both risk as well as benefit. And appropriate care, I think, is important to define, where appropriate care is when we expect the benefits to exceed by a wide margin the risks. And knowledge of the expected benefits and expected risks is really fundamental to empower and informed choice for both physicians, surgeons, and patients, most importantly. So I think that the optimal management for complex spinal disorders really requires systematic protocols that involve preoperative optimization, some intraoperative standardization, as well as postoperative accountability. So for every phase of care, we've got opportunities to optimize our pathways. The next slide, please. Complex spinal disorders in general, the definition that I've given in prior publications include disorders of the spine, be it pediatric or adult, that involve symptomatic neural compression or that involve some degree of malalignment, especially malalignment that's likely to be progressive without surgical intervention. And some of the examples I might give include early onset scoliosis, adult and pediatric deformity of the spine, cervical and thoracic myelopathy, tumors of the spine. I added to this infection and other conditions of the spine in the most recent version. But let's go to the next slide, please. And this just demonstrates some examples of complex disorders. Is neuromuscular curves, infectious disorders, tumors, and significant deformity of the adult and pediatric spine. Next slide, please. So when we think about priorities for our healthcare systems, again, internationally, our health system priorities really are defined by the prevalence of the disorder and really how much of the population the disorder impacts. How much of our healthcare system requires utilization for care for the disorder that gets into the economic costs and the impact of the disorder. So the impact of the disorder regarding disability and the impact on health-related quality of life. Next slide, please. And when we think about the impact of spinal disorders and health-related quality of life, many of you are familiar with the global burden of disease studies, looking at over 220 common conditions and the impact on these conditions on quality of life. Next slide, please. So this was an international study that involved over 40,000 people, looking at impact of a variety of different disorders. I think most of you are familiar, next slide, please, that disorders of the lumbar and cervical spine were really among the most impactful disorders across the world. Next slide, please. And some of the work done by the European Spine Study Group and Ferran Pellicer being the lead on this, looking at adult deformity specifically and the impact of adult deformity and health-related quality of life, comparing this to other common conditions, including diabetes, chronic lung disease, congestive heart failure, arthritis, and demonstrating quite clearly that deformity and complex deformity in the adult spine really has a larger impact in every domain of health-related quality of life across the SF-36 scales. Next slide, please. So clearly, we as a community of physicians who care for disorders of the spine are caring for a disorder that's a priority for our healthcare systems internationally. So let's talk a bit more about then management and specific strategies for how we manage complex disorders. I think it's important to recognize the variability in how we may approach common problems. And certainly the role for non-operative care, rehabilitation, injection, medications, bracing, neuromodulation, variability in strategies and dramatic differences in the invasiveness of different options. The role of circumferential fusion has been spoken to quite a bit. The role of biologics in spine surgery, minimally invasive versus open approaches, and navigation and robotics. I spent some time in the vendor area, in the exhibit area, and some very nice demonstrations by some of the sponsors of some new robotic techniques. Next slide, please. And again, management of complex disorders of the spine is really characterized by significant variability. There's a lot of variability in the clinical presentation of patients and a lot of variability in clinical strategies. And this variability isn't a nation to nation, and in many areas it's region to region or even hospital to hospital. And so across the world internationally, we see the opportunity for significant variation. We also see, I think, through conferences like this, the creation of opportunities for convergence and for learning from one another. And that's why I think this is such a wonderful opportunity for us to have a Congress and symposium together. Next slide, please. One of the aspects of variability that's important to recognize is, to some extent, excessive variability is really a proxy for poor quality care. So reducing variability really becomes a goal. And to that end, what are our opportunities to build consensus? I think we've got several resources, including clinical practice guidelines, as well as appropriate use criteria. I'll speak to each briefly. Next slide, please. The North American Spine Society has available online some really terrific clinical practice guidelines that I've contributed to, and many others have nationally and internationally, looking at specific diagnoses. So ischemic spondylolisthesis, spinal stenosis, degenerative spondylolisthesis, and giving guidelines that are evidence-based for appropriate management of general conditions. Now, for the individual patient, next slide, please, oftentimes the appropriate use criteria may be useful. And for the individual patient, we can actually judge the appropriateness of surgery. And again, where appropriate care is care in which the expected health care benefit exceeds the expected negative consequences of care by a wide margin, such that the procedure is worth doing. Now, in contrast, an inappropriate procedure is one where the expected harm may outweigh the expected benefits. Next slide, please. And this was quantified quite nicely by the UCLA group in an article by Fitch in the Journal of the American Medical Association, looking at this on a 9-point scale, where the most appropriate surgery are procedures where the benefit clearly exceeds the risk, and the most inappropriate are where the risks clearly exceed the benefit. Oftentimes in complex surgery, we're operating in a realm of reasonable. Next slide, please. To that end, we looked at this using appropriateness criteria for adult scoliosis, and the real drivers of appropriateness for surgery were patients who had more severe preoperative symptoms, patients who had more of a progression of deformity rather than static deformity. Sagittal malalignment was a priority, and importantly, driving against the appropriateness of surgery were patients with major comorbidities or high risks of surgery. Next slide, please. So optimal care then is patient-centered care. And to provide optimal care, we need information on the natural history of disorders, the expected outcomes of care, be it non-operative and operative, and expected risks of care. And that's why it's so important that we carry on with outcomes research. Next slide, please. And of course, optimal care being very much focused on the individual patient and their conditions. Next slide, please. Please go ahead and advance the slide if you would. We wrote about this as an international consensus that was sponsored by the AO Knowledge Forum for Deformity. And in this consensus, and this is quite worth looking at, we looked at defining the goals of surgery and what are appropriate goals. And we concluded with consensus that goals for improvement of neural status, improvement of pain, improvement of function were reasonable goals. We also identified some preoperative identification of risk factors, and there was clear consensus on identifying patients who were smokers, who had significant comorbidities, cardiopulmonary disease, osteoporosis. Where there was not much consensus is intraoperative strategies. So really not a clear guidance on when we ought to fuse to the thoracolumbar junction versus the upper thoracic, what we ought to do with pelvic fixation, when we ought to go circumferentially. And that's where further research really is needed. Next slide, please. So in terms of what can we and how can we improve and optimize systems, well, one part of this is developing interdisciplinary teams across the spectrum of care. And next slide, please. And for patients with complex spinal disorders, we recognize that there are multiple providers involved in these patients' care. Next slide, please. These providers certainly include the surgeons, neurosurgeons, orthopedic surgeons, but also non-operative specialists, pain management doctors, physiatrists, radiologists, physical therapists, and importantly for infectious disease and for tumors, our oncologists and our medical colleagues, our primary care doctors, and engaging everybody as part of a team. Next slide, please. Engaging everybody as part of a team, working together with a shared goal. Next slide, please. Just as any team would have with success. So I'm going to wrap up with these specific guidelines. Number one is preoperative considerations, the importance of assessing risk and benefit, assessing the appropriateness of surgery, aligning patient expectations with observed outcomes, and empowering patients to make shared decisions. One of the areas where we can optimize is preoperative medical optimization, smoking, nutritional status, obesity, diabetes. Many of these conditions are modifiable. Next slide, please. And I'll show you in real time what happens in my clinic. This is from my electronic medical record. And when I'm scheduling somebody from surgery, I simply type in a dot phrase, dot pre-op op, and it comes up with somebody's blood sugar. So I won't do an elective spine surgery on somebody with a hemoglobin A1C more than 7, somebody with osteoporosis, somebody with a body mass index more than 35, somebody with a serum albumin more than 3.5, active smokers, patients who are taking more than 50 milliequivalents of morphine per day, patients with reversible systemic diseases, patients without adequate social support, patients with untreated anxiety or depression, and patients who are frail. So only through screening for all of this can we identify problems. And many of these things are modifiable that I'll try and modify before doing elective surgery. Unfortunately, in many instances, surgery might not be elective, so we still need to operate. But for elective surgery, I'll try and optimize all of this. Next slide, please. And I think as we develop more predictive models, recognizing for the individual patient with specific comorbidities, with specific presentations clinically, what are the likely outcomes clinically, what are the likely complications, and what is the appropriateness of surgery? And as we develop these models, I think this will be an important preoperative goal. Next slide, please. Intraoperatively, having standardization, how we manage blood loss, how we conserve fluids, how we resuscitate patients, nerve monitoring, our surgical techniques. For most complex spine surgery at UCSF, we'll use 2 attending surgeons and really trying to do our best to reduce complications with intraoperative strategies that are based on evidence, be it how we do pelvic fixation, where we what we do with our proximal segments and avoiding PJK and optimizing our chance of spinal union. Next slide, please. Just 2 more to get through here. Post-operative considerations, managing pain, early mobilization, and Dr. Shirok is going to talk next about those type of intraoperative and post-operative considerations. DVT prophylaxis, avoiding delirium in patients after surgery. Next slide, please. And then finally, discharge, really making sure that pre-operatively we prepared patients to get home. They've got appropriate family support at home. We've got a nurse navigator who communicates with the patients, bringing patients back to clinic rather than emergency visits, and measuring our outcomes so that we can assess how well we're doing with different procedures. Next slide, please. So finally, in conclusion, complex disorders of the spine and spinal disorders in general present a significant burden to our healthcare economy and are an important priority for our healthcare systems internationally. I think that optimal management, especially of complex disorders, requires an interdisciplinary team with reform that includes optimizing our non-operative pathways, pre-operative optimization, intraoperative standardization, and post-operative accountability. And ultimately, what's needed is medical center investment into system reform and investment of surgeons as a priority for patient safety and for optimal patient care. So thank you for the opportunity to contribute to the Congress, and I look forward to further discussion.
Thank you, Dr. Barwin, for a nice presentation. I thank you on behalf of the ASSI. And it was nice to know that good outcome is a matter of teamwork and having protocols in place. Now I invite the second speaker, Dr. Alok Sharan from New Jersey, to talk about enhanced recovery after lumbar spine surgery, a concept of awake spinal fusion. Dr. Alok Sharan, please. Can you play the presentation?
Hello, and my name is Alok Sharan. I am an orthopedic spine surgeon in New York and New Jersey, and I'm the Director of Spine and Orthopedics at NJ Spine and Wellness. I want to thank you for the honor of inviting me to speak today at the ASSICON 2021 meeting. I'm sorry that I can't join you in person, but of course, virtual is the next best thing. So I truly am honored to speak about our enhanced recovery program after lumbar spine surgery, awake spinal fusion. Enhanced recovery has made some tremendous advancements in surgical care over the past decade. Originally, ERAS was applied to GI surgery, but there has been, over the past few years, a broad adoption of ERAS principles in spine surgery. Originally, the goal of ERAS was to promote a faster and easier recovery. In spine surgery, the goal of ERAS has been to get faster mobilization of patients after surgery, better pain control with less narcotics, quicker discharge, and of course, an overall return to work, sports, and activity at a faster, more efficient rate. For the past few years, I have been performing a procedure called the awake spinal fusion surgery. Ultimately, awake spinal fusion surgery is an enhanced recovery protocol that allows patients to recover faster, mobilize quickly, with overall less pain. We have performed 135 awake spinal fusions to date. Our average length of stay for a patient who undergoes a single-level lumbar fusion using our awake spine protocol is 0.8 days. 50% of our patients are able to go home on the same day, and about 70% of our patients are off of narcotics after 1 week. To perform awake spine surgery, our protocol entails, from the beginning, proper education of the patient, proper risk stratification of the patient, and from an anesthesia perspective, using spinal anesthesia and a novel regional block called the Tila block. Since we perform these surgeries using minimally invasive techniques, Many patients don't require much narcotics post-op, and that's critical for achieving awake spinal fusion surgery. Now, anesthesia has evolved tremendously for spine surgery. The use of spinal anesthesia has been reported for many years now, and there have been a lot of good studies that have demonstrated the advantages of using spinal anesthesia versus general anesthesia. The novelty of the awake protocol, though, comes in performing this novel regional block called the Tila block, thoracolumbar interfascial plane block. First described in 2015 in the Canadian Journal of Anesthesia, the Tila block is a regional anesthetic technique that blocks off the dorsal rami nerve and its branches in the interval between the multifidus and the lumbaris muscle. Typically, the Tila block is performed using ultrasound to catch this interval. What we do is deliver medicine into this space over here. I typically use Exparel, which is Marcaine, which essentially lasts for 48 hours. On the picture on the right, you can see the ultrasound picture of the paraspinal musculatures. With ultrasound, we're able to find the plane between the multifidus and the lumbaris, and using a needle, we're able to essentially deliver medicine to that space. When performed properly, many of these patients have no pain or minimal pain after surgery. In the original study that was performed, the authors performed the Tila block on healthy volunteers. They used ropivacaine 0.2%, 20 milliliters on each side. They measured their sensation and the anesthesia both at 5 minutes and 20 minutes after surgery, and you can see a dense anesthetic effect of performing the Tila block. There have been numerous studies now that have looked at the use of the Tila block in lumbar spine surgery, and in one of the first studies that were ever published from Japan, 72 patients were randomly assigned to receive general anesthesia versus general anesthesia with the Tila block. Using 40 millimeters of levobupivacaine, performing surgery lumbar laminoplasty, the authors were able to lower the fentanyl requirement and lower the VAS scores in these patients. We've subsequently been using the Tila block along with spinal anesthesia, and as you can see in this graph over here, we've been able to get a significant reduction in postoperative pain for these patients. Beyond the reduction in pain, though, many of our patients require minimal to no narcotics after surgery, with about a 76% reduction in opioid use. But what's been really exciting about the use of the protocol has been the fact that we've been able to discharge many of these patients home the same day. Our average length of stay now, as I mentioned previously, is 0.8 days for a patient who undergoes a single-level lumbar fusion. Here's a perfect example of a gentleman who had undergone our awake spinal fusion. This is Kevin. You can see his picture on the right-hand side. And on the left-hand side, you can see his MRI. Kevin had a herniated disc and had undergone a successful microdiscectomy. Unfortunately, he re-herniated and developed degenerative disc disease. So the question was, should we perform a revision microdiscectomy or should we perform a lumbar fusion? After a long discussion about the benefits and the downsides of each approach, we elected to perform a lumbar spinal fusion. And typically now, when we perform our awake protocol, about 4 hours after the surgery is done, we're able to get the patients up and walking, as you can see over here, where Kevin has about 4 hours after surgery, up, walking, getting ready to go home. And these are the kind of results that we're seeing now with this. Awake spinal surgery has been becoming commonly adopted now. There are, of course, many centers in the United States that are beginning to perform awake spine surgery, awake endoscopic surgery. But what's been great is that many of these centers are seeing similar results to ours, which is a significant reduction in narcotic usage and a significant reduction in length of stay. Beyond that, we're seeing significant international adoption of awake spinal fusion. I'm currently working with a group right now in England that's developing a awake spine surgery protocol. A good friend of mine in Italy is performing awake XLIX procedures. And many of you know that a few years back, I came to Pune, where we performed one of the first awake spinal fusion surgeries at Sancheti Hospital with similar type of results. So it's been great to see the adoption of this procedure overall. And now we're seeing greater and greater literature around this. A lot of published data is starting to come around the use of awake spine surgery. So it's been a major advancement now in spine surgery. To me, awake spinal fusion is essentially an ERAS protocol for lumbar spine surgery. I encourage all of you, if you're interested in learning more, to register for an online learning platform that we created called Doc Social, where we have on there a lecture about how to perform awake spine surgery. Thank you. I thank you again for the honor to speak today at the ASSICON meeting.
Thank you, Dr. Sharan, for a nice presentation on how to do surgery and fusion surgery under spinal anesthesia. We have the discussion and the questions at the end. I now invite Dr. Bala Venkat from Ganga Hospital to tell us about the current concepts of multimodal anesthesia and optimizing post-operative pain.
Good morning, everyone. At the outset, I would like to extend my very sincere thanks for giving me an opportunity to be a part of the annual convention of the Association of Spine Surgeons of India. Today, I'm going to share a few of my thoughts on a very pertinent and important topic in the preoperative care of a spine patient, the current concepts of multimodal analgesia and optimizing postoperative pain. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore. And as all of us know, postoperative pain is a combination that results due to both somatic and emotional component after surgery. The intensity decreases over time, and usually it is located in the proximity of the surgical lesion, can increase the risk of postoperative complication and delayed recovery if it's not taken care of. The incidence, the duration and the intensity of the pain varies considerably from one patient to another. There are several factors which result in this. Number one, because of the patient per se, and very importantly, now it has been noted, the pharmacogenetics and the pharmacogenomics of analgesic drugs working on a particular patient. For the same dose that we give, different patients of the same body mass index give varying results. Some of them have very good pain relief and some not. And now we understand this due to pharmacogenetics, which changes which happens in these patients, and it's a new topic for discussion. Next thing is the surgical procedure per se and the amount of tissue injury which happened. Third, how do hospitals respond to acute postoperative pain and how they've developed their acute pain service. And number four, the perioperative analgesic plan, and sometimes even the country and the culture matters in postoperative pain. Are we doing enough for our patients? Several studies have clearly indicated that acute postoperative pain is unacceptably high even in developed nations. I just wanted to share with you the Assist Patient Survey, which I was the principal investigator. The aim was to compare pain scores at rest and ambulation and to assess patient satisfaction between the different modalities of pain management at different time points after surgery. And this was an investigator-initiated prospective multi-centric trial from over 12 centers in India involving 1,046 patients, out of which 32% were spine patients. So the methods included pain scores, patients and caregivers' satisfaction toward postoperative pain, treatment and overall pain management at the hospital were captured at 3 different time points through a specifically designed questionnaire. And the conclusion was, this survey clearly indicated in Indian subcontinent that the current standards of care in postoperative pain management remain suboptimal, and that acute pain services, wherever it exists, is yet to reach its full potential for affording pain relief to our patients. Why should we insist on postoperative pain? It reduces, if the pain is unrelieved, it reduces the mobility, increases the stress and anger, and also impairs the respiratory function. It also produces immune depression, and there is metabolic hyperactivity and negative nitrogen balance, which will impair wound healing, and there is impaired bowel movement. And some of the visceral complications include myocardial infarction and ischemia, tachycardia, dysarrhythmia, thrombolytic events, metabolic acidosis, and significant peripheral vasoconstriction. And hence, the potential benefit seems to outweigh the complications. So improved rate of recovery, improved patient comfort, reduced morbidity, and faster discharge. And it's also been very clearly noticed that acute postoperative pain, if it's not relieved, it results in prolonged postoperative pain. There's an excellent article which shows that quality care has to be given, and quality has been defined as 6 domains of effective, equitable, timely, efficient, safe, and patient-centered measures, in which one of the most important thing is pain relief. Pain after spine surgery results from pain generators, and now the new concept is procedure-specific treatment to be offered in each spine surgery. So pain from the back actually originates from different tissues such as vertebra, intervertebral disc, ligaments, dura, nerve root sleeves, facet joint capsules, fascia, and muscles, which all generate pain. And the spine pain, I just wanted to emphasize, is we are fortunate that there is no visceral component, and everything, the pain perception is carried through the posterior rami of the spinal nerve, which gets connected to the sympathetic and parasympathetic nerve. A point that I just wanted to mention is there is a cross connectivity of these nerves, and that's why in spine surgery, sometimes apart from the local pain, there is referred pain that is happening. The types of pain are divided into nociceptive, inflammatory, and neuropathic. It's important to understand this so that we can go for a multimodal pain relief in our patients. So what do we do when we get to the spine patient? This is an excellent concept of preemptive analgesia. The night before surgery, in all of our patients, we put this to prevent peripheral and central sensitization. So on the day prior to the surgery, they get pregabalin 75 milligram, a non-steroidal anti-inflammatory drug like aceclofenac 100 milligram if the renal parameters are normal, 1 gram paracetamol, pantoprazole, and alprazolam to produce good sedation and anxiolysis. In some centers, they use statins for its anti-inflammatory effect. We don't use it. So this is on the day prior to the surgery. On the day of the surgery, the 0-hour medication is to augment the preemptive analgesia. So we use paracetamol intravenous. Ketorolac 30 milligram is given intravenous if it's the renal functions as normal. Dexamethasone 8 milligram is given for its anti-inflammatory property as a component of multimodal. Then we use opioids, and the drug of choice we use is fentanyl. So this is a 0-hour medication, and this is another component of preemptive analgesia. And once positioned, and the surgeon in our institution, the spine surgeons, do local infiltration with local anesthetic solution in skin and subcutaneous tissue to decrease the pain generation from this when the incision is made. The preoperative regional anesthesia nerve block, I think it's the future to decrease significant pain. I'm going to discuss with it in a minute later. And intraoperative analgesia is mainly dependent on opioid infusions, fentanyl and remifentanil, paracetamol, dexmedetomidine, and the drugs which have been tried in several centers across the globe. Apart from this is ketamine, magnesium, and lignocaine. We predominantly depend on fentanyl infusion, paracetamol, and dexmedetomidine. And post-operatively, to continue the pain relief, I think one of the significant issues in the post-operative period in spine surgery is the pain. And we have to evolve tools to know how much is the pain. And the best way to do is the numerical rating scale, the VAS score, and Magel pain questionnaire, and the new score for spine surgery is Roland Morris score. I would wanted the surgical team to discuss with the anesthetist the plan to assess the pain. So the intensity of the post-operative pain is directly proportional to the number of vertebrae involved in the surgery. Now, in a multimodal analgesia, you try to use various combination of drugs so that they collectively produce a synergistic effect. So on post-op day 1, they should get 4 grams of paracetamol, 1 gram paracetamol 6th hourly, non-steroidal anti-inflammatory. The one which can be given intravenous is injection ketorolac, 30 milligram IV 8th hourly, and pregabalin 75 milligram in the night, dexamethasone 8 milligram, a dose at 0 hours and after 8 hours. And apart from this multimodal therapy, you may use opioids as a rescue. And in patients in whom you don't want to use opioid, the weaker drugs like tramadol and tapentadol can be used. Slow release buprenorphine patches seems to aid, and we use 10 milligram buprenorphine patch. Once you apply it preoperatively, it stays for a week, and it's a slow release and does not produce any respiratory depression. And the most important thing that has evolved in the last couple of years is ultrasound guided regional block for our patients who are undergoing spine surgery. So there is a ladder: mild intensity pain, moderate intensity pain, and severe intensity pain, where you keep increasing the doses of the drug and the number of times it's administered. And the newer concept, which I just wanted to speak in the last couple of minutes, is the chest and the abdominal wall blocks. And this seems to offer the best component of multimodal analgesia. It reduces the pain scores in the first 24 hours, reduces the opioid consumption in the first 12 hours, does not produce nausea, vomiting, less sedation, early weaning from ventilator if you're ventilating your patients, and very short hospital stay, and less incidence of chronic pain. So what do you actually do? The intercostal block is what we do, and currently for all spine surgeries, it's the erector spinae block, where you deposit the drug between the transverse process and the erector spinae muscle. So here it is what is the drug is deposited. So this is a schematic diagram which shows between the transverse process and the ESM. If you place the drug here, it blocks both the dorsal and ventral rami and completely cuts off the pain sensation to the spinal cord. So this is how you place the drug between the transverse process and the ESP. And this is excellent for spine surgery. This is the sonoanatomy, the three muscles, the transverse process, and the drug will be deposited here. This has made a huge change and impact, and continuous erector spinae catheters can be placed in major spine procedures using elastomeric infusion pumps. The other thing that has evolved now is local infiltration analgesia, called surgical site catheter, where the surgeon places the catheter inside the surgical wound and connect to an elastomeric infusion pump. This seems to be yet another mode of producing regional anesthesia at the local site as a component of multimodal analgesia. But a multimodal analgesia it means that more than one mode, which consists of paracetamol, non-steroidal anti-inflammatory drugs, pregabalin, regional anesthesia, and if in spite of this the patient has pain, then you go for opioid. Best is to go for opioid sparing. So effective pain control aided by the judicious use of different pain control therapies can significantly improve the overall success of surgery. Thank you very much for the opportunity, and I'm sure that from now on we'll get excellent results by incorporating multimodal analgesia in spine surgery. Thank you very much.
Thank you, Bala, for a very informative talk. May I invite Dr. Arvind Kulkarni? He'll be speaking on checklist for safe spine surgery. Arvind?
Good evening. Checklist forms the backbone of major industries, major enterprises, and even household activities. In fact, the virtual meeting that we are having right now is programmed on a checklist. Checklist is basically an aid which helps in achieving success and prevents failure by compensating the weaknesses of human memory, forgetfulness, and distraction. It increases efficiency by adopting simple steps such as task and tick. COVID has shown us how to follow a checklist. For the last 1 year, each household and every surgeon has been following a checklist. Talking about hospitals, hospitals can be called disaster zones because majority of complications, mishaps that happen secondary to surgery are a result of a surgery itself. And out of close to 234 million people operated every year, at least 1 million die as a result of complication which can be avoided. So that's why the WHO embarked upon coming up with a checklist which has had a major impact. There is striking evidence to show that the infection rate is reduced by 50%, the death rate is reduced by 50%. Even Indian experience as derived from Dr. Shimran Nandi from Gangaram Hospital, whose unit adopted this particular checklist, remarked that this particular checklist is beneficial. So my own experience, this elderly gentleman underwent a laminectomy for cervical myelopathy. As soon as the laminectomy was done, he started bleeding from various sources. There was cluster bleeding, and which was uncontrollable. And to make things worse, our unit had forgotten to do a grouping and cross matching, and this sadly ended up in intraoperative death. Again, this is a common scenario. This happened with me, and the pedicle screw became loose. The pedicle hole was in bigger size when I tried to put a S1 pedicle screw, and we didn't have a rescue screw at hand, and we had to wait for the rescue screw to come. So the patient was under anesthesia for close to 1.5 hours till the rescue screw came, and so this was basically a waste of time and unnecessary exposure of the wound to pathogens and the patient to longer stages of anesthesia. Again, I do tubular surgeries, and the tubular set was missing when on 2 occasions because it was lying in some other hospital. So this is because in Bombay there is a general tend to get attached to various hospitals, and this was a very silly mistake. So why do such unpleasant things occur? Is it because of failure of expertise? Is it because of failure of super specialists? Is it failure of medicines, failure of sophisticated devices? None at all. This is all a failure of oversight, overconfidence, and a casual approach. So that is where the checklist makes a difference. The checklists do not teach you how to operate a complex case of scoliosis. Instead, they provide reminders of only the most critical and most important steps, the ones that even the highly skilled surgeons usually tend to miss. So there are other causes also, like surgeons fatigue, etc. But the most important striking cause, for having such kind of unpleasant complications is failure of teamwork. Teamwork is very important. The surgery is like an orchestra. To save one life, scores of people, the nurses, the operating staff, the fellows, the residents, the surgeon, have to perform 1,000 things correctly in a stepwise manner and simultaneously for a successful outcome of surgery. That's why surgical checklists make a big difference in major industries. The success of these major enterprises is solely because of following a checklist. So the WHO, as you see, came out with this very popular and well-established checklist, which has saved many lives across the world. However, it is generic. It is not specialty or subspecialty specific, which is very important because, like for example, spine has its own unique set of complications, that is wrong level surgery, which cannot be, which is a totally different, piece of cake. Now, surgery doesn't mean just the operation. It extends from the time of admission till the patient is discharged. So our checklist has 3 components to it. So the first component is very, very important in planning surgeries. So all the battles are first won in the mind. So all the surgical steps go through the surgeon's mind prior to surgery. That directs the success of surgery. So then is the intraoperative component, which basically includes the components of WHO plus components specific to surgery. And then comes the phase of complications. So we have designed a pre-operative checklist, which goes to the patient's demographics, the necessary, paraphernalia that is necessary for surgery. Then intraoperatively, it is basically a check on antibiotics, positioning of the patient, the counts, the drain tug, etc. And then most importantly, which we included is the post-operative, which also includes the red flag signs that are explained to the patient prior to discharge, so that if there is a complication, they come back to you, or at least get back to you on your mobile, etc. So this study, basically we use the checklist in this particular period, 2018-19, and then compared the adverse outcomes with the preceding year. And this is, as I showed, this is a 37-point checklist, which covers the perioperative time. And there was remarkable, there's 75% reduction in preventable errors in our unit. Our unit was already quite vigilant because we used to keep a check on everything. In spite of that, we could still reduce it by further 75% when we started following this particular checklist. So these are all the adverse events. You can see, preventable adverse complications from 56, it came down to 15. So 56 out of 393 patients had issues prior to implementation of the checklist, but this reduced to 15 out of 428 after implementing the checklist. And following a checklist is a routine for us. It is nothing new. You don't have to be stressed about it. We have always used checklist for pre-operative fitness, as shown on the left side, and we also have followed a checklist in response to a intraoperative mishap which was picked up by intraoperative neuromonitoring. So we are conversant with the utilization of a checklist. So why reinvent a wheel when WHO already has a well-established checklist? That is because spine is a totally different arena. Spine is a very complex surgery. So it reflects the height of permutations of combinations. There are different regions, there are many junctions, there are multiple levels. Again, there is right and left, then there are various approaches, then there are various types of surgeries, decompression, fusion, and if you fuse, if the patient has enough bone graft in himself, or do you need substitutes, or if you want to use components like bone cement for stabilization, etc. Then imaging is a very integral part of spine surgery, whether it is just C-arm, whether it is X-ray, or is it a complex surgery which needs navigation. So there are a lot of paraphernalia which may be necessary, and without which a simple surgery can become complicated. So these things have to be kept in mind, because absence of one particular gadget or infrastructure can ruin or lengthen the entire surgery and turn it upside down. So again, why a spine surgery checklist suits our milieu? Because there is significant stigma associated with spine surgery. We are always carry this on our back, that is a failed back syndrome, which is quite an infamous phrase. And again, the kind of complications we face are irreversible, unpardonable. Again, the amount of money that patient puts in from the pockets, if he's not insured, is tremendous. And if there is a complication, it multiplies ample number of times. Again, our OT boys, OT technicians, nurses are untrained many of the times, and so we use technology, and if they're not conversant with, you can end up in complications. And being in India, we face high volume of surgeries, so there is a lot of distraction. There is a lot of lack of concentration when you're operating on too many cases. Again, there is limited and bizarre distribution of resources. For example, in a population of 20 million in Mumbai, there are 2 or 3 sources of neuromonitoring. That is the kind of ratio we have. Again, we don't have stationary inventory in the operating room. We order implants, so there is possibility of a limitation from the vendor's point of view, which can have an impact on your surgery. Again, our fellows change, resident change, but the rules have to be the same. So that's why checklist is like a Bible for your unit. Again, unlike other countries, we have very poor and disconnected, surgeon GP algorithm in case a patient develops post-operative complications. So checklists bring discipline, checklists give guidance, checklists aid in decision making, and checklists, most importantly, foster communication and teamwork between the surgeon, between the fellows, between the radiologists, between the nursing staff, etc., so that everyone, there is a team behind the success of surgery, and that is fostered by use of a checklist. So checklist allows surgeons to concentrate on non-mundane stuff. Checklist is application of knowledge we have consistently, correctly, and reliably. Checklist is making things happen correctly. Checklist shows that each problem has steps of solving. Checklist shows that each step is important. Checklist shows that the more you repeat it, the more you master it. Checklist reduces error making. Checklist reduces complexities. Checklist offers the possibility of verifications, establishes effective teamwork. It helps on effective utilization of resources and skills, helps to improve provision of quality services, provides customer satisfaction, and provides reminders of the most critical and important steps. So the next step would be to involve multiple centers to check the efficacy of this checklist. So this particular checklist that we're using is efficient, reliable, cost effective. Of course, there is a learning curve attached to its usage. It is definitely subspecialty specific, and we have seen that it reduces miscommunication among primary surgeon, training fellows, and the OT staff. And of course, it can be modified and it can be customized to your local operating milieu. Thank you very much.
Thank you, Arvind. If there are any questions from the moderators or the panelists? So let me start by asking Dr. Burman, how do you, I had written it on the chat also, how do you see that the normal routine activity of the other departments where you are taking the consultations from are not disrupted? I mean, how do you manage all that?
Yes, when we're creating interdisciplinary teams, it's awfully important to create pathways that are compatible with other workflows. So for example, specifically between surgery and anesthesia in the preparation of a patient for surgery, we've actually built into the workflow, part of the scheduling process is that I can order a consultation with the anesthesiologist prior to surgery. So for somebody who I'm concerned about comorbidities, so the anesthesiologist doesn't see the patient 1 or 2 weeks prior to surgery, but rather 3 months prior to surgery to really alert the anesthesia team. Smoking cessation programs, having an order set that automatically puts a patient who's an active smoker into a smoking cessation program. Pain management, I was very interested in Dr. Venkat's lecture from Ganga in terms of the interaction of anesthesia and surgery with regard to perioperative pain. So the subset of patients who are taking narcotics prior to surgery, especially higher doses of narcotics, making sure that those patients are seen by our perioperative pain service before surgery. So all this, I think, can be effectively accomplished with order sets that are built into the workflow.
Thank you. Thank you. Dr. Shankar, do you have any questions?
Yeah, I have a question to actually Arvind. Arvind, that's a very nice paper, and I'm also going to ask you to write on the checklist. But I have a problem with the checklist. The problem is whenever you duplicate a checklist, then there is always tendency to skip or error. As you know, in our hospitals, we have multiple checklists. The nurse has a checklist, the technician has a checklist, and our hospital has a detailed checklist. So when I heard your lecture I think a year or so ago, when I tried to introduce a new checklist, ultimately what happened is that all three became incomplete. So what's your suggestion? Because hospitals have their own system, and we have an HIS inbuilt computerized system. And when you these systems are so integrated that when you want to introduce any extra thing into these systems, there is resistance from the EMR developer or the EMR people. And I would also request Dr. Burman to have a comment, or anybody, or allowed to make a comment, or anybody to make a comment. When you are in an individual setup, or if you have your own hospital, you can easily introduce a checklist which works for you. But when you are a multi-speciality hospital like ours, what do you do?
So our checklist is not integrated to the hospital at all. I go to 3 hospitals. So this is worked on my fellow's laptop. So right from the day a patient is suggested surgery and he agrees for surgery, you start ticking in, because even intraoperative monitoring in Bombay, we have to sometimes book about a week to 10 days in advance. So this has nothing to do with the hospital system at all. It is our own institution. Our unit is an institution in itself. And when that particular fellow is washed up, the other fellow sees to it that, the intraoperative details are checked in. Whether you've done a final tightening or not, whether drain tug is done or not. So at every step, we make sure that this is done, and this keeps repeating itself. So the only issue is when one of these fellows is on leave or things like that. So it gets a little compromised. But as much as possible, it's very simple and easy to follow.
Yeah, I understand that. That's
As
only
long
when
as
the one checklist, but we have to fill our hospital checklist. Just as I'm having difficulty with my fellows putting in the ASSI data in the Bharat Dave's registry. They say, sir, we are having a duplication of thing because we have to put it in our hospital system before coding can occur, and then we have to again upload in the ASSI website. And I've tried my
The
best.
problem in India is typically two things. One is healthcare essentially means surgeon care. It means nothing else. There is no responsibility either of the paramedical staff or the orthotists or the physiotherapists. And therefore, the load of delivering all this, if you introduce a safety checklist, it's going to be your headache. It is not the headache of the hospital. And the only way is if the hospital, rather than you talking to nurses, actually decides. The same problem I had when I started the ERAS program in Jaslok Hospital about 5 years ago. And what happened was that the pressure to deliver is entirely on the surgeon. Sometimes the anesthetists are not comfortable with euvolemia, so then it becomes difficult to deliver this kind of care. So therefore, we found that this is the biggest hurdle in India, that the whole responsibility for the healthcare is not divided among nursing staff, administrative staff, etc. It is entirely dependent on the surgeon. And therefore, if you're going to do checklists, 100% you have to do it, or at the very least, it is your second in command or your fellow. Beyond that, you will not be able to actually implement it in most hospitals under the circumstances that we work in. However, let me ask a question to Dr. Bala Venkat. Sir, what I find is it is extremely difficult to plan analgesia for elderly individuals above the age of 70 or 75. Their tolerance to most drugs is very, very poor. And invariably, I find that we eventually end up giving them less pain relief than they deserve. And how do we overcome that? I find pregabalin is extremely poorly tolerated by most of my patients. If I give pregabalin to a patient, especially it's a woman, and especially if it is an older woman, 100% they will call me up that I've got nausea, vomiting, headache, giddiness, and the phone comes to you. That's the last thing a surgeon wants, that he doesn't want phone calls from patients for all this bullshit. So how does one avoid all this?
I think, thank you, Dr. Gautam. I think one of the most important thing which has happened in the last couple of years is incorporating regional analgesia to all your patients, especially geriatrics. And we had a nice talk on thoracolumbar interfacial plane block, which Dr. Alok mentioned, and also the one which I mentioned, which the surgeon can perform themselves, even if the anesthetist doesn't want to do. All that is, you need to deposit the drug between the transverse process and the erector spinae muscle. I think this is the best answer to your question, in that it considerably reduces the pain, and especially when we add an adjuvant of dexamethasone to the local anesthetic solution, we don't have exparel like what Dr. Alok has. That is a liposomal bupivacaine, which we don't have it in India still. So if we want to prolong the duration, the local anesthetic with 4 milligram dexamethasone on either side. So bilateral ESP seems to be the answer for your question. Along with this, the safest is paracetamol. If they have no contraindication, like 1 gram 6-hourly is the ideal dose for surgical analgesia. So these two things will do the trick, even if you don't want to give a non-steroidal because it's a geriatric patient.
Can I ask one question to Dr. Bala? Maybe Dr. Alok Sharan can also contribute to it. So usually in my unit now, people have started doing endoscopic surgery. So the problem, the patient is placed in prone position, and in local anesthesia we are doing. Many of the patients, they are not able to tolerate that prone position, more so the elderly, they start moving. So do you have any protocol for that? You give either sedation or some medication during that period? And even Dr. Alok Sharan is doing fusion, fusion in awake position. So have you seen this problem? Positioning the patient in prone sometimes they are not comfortable.
So I think Dr. Alok will have to say this, but we don't do it in awake, sir, except for vertebroplasties and high-risk critically ill patients where we avoid GA. But most of our patients, as you rightly said, lying down in prone position has to be very selective, because especially in obese and geriatric patients, and some of them are very anxious. So I think Dr. Alok will give more insights into this. Patient selection will be very crucial when we want to do awake spine surgery in prone position.
Thank you. Thank you for the question. Can you hear me?
Yeah.
So it is very challenging. I think first and foremost, you have to discuss it with the patient if they can tolerate being prone. So I ask them, do they sleep on their belly at night, or do they sleep on their back? And if they do sleep on their belly, do they have any problems? So that's the first question. We use a Wilson frame for both our laminectomies as well as for our fusions, because we find that with the Wilson frame, the patient has more support as opposed to using a Jackson table, because they feel more scared. So that's the second thing. Third is that when the patient is prone, it's critical that they don't get disinhibited. So I don't like using propofol, for example, because the patients get disinhibited. At most, we give a little bit of Versed and we give some Benadryl, and we find that they're okay if they're a little bit sleepy. There's a medicine called Precedex also. So we find that actually is very helpful to keep them in a position. You never want them to be disinhibited, because at that point, that's when they start to move. So you want them to be, they have to forget about the surgery, but not at the point where they can't respond to your command.
Thank you, Dr. Sharan. I think we are running out of time, and we need to end the session to begin the next one. I thank all the speakers for their excellent presentations, and all the moderators and all the questions that enrich the session. Thank you, and we end the session now.
Thank you.
Thank you.